Hello everyone. This is the case discussion. I'm the MC of this discussion. We have invited 3 clinical masters to this discussion: Dr. Kim Kyoung-won, Professor Kim Yeong-taek, and Dr. Park Jong Hyun. Hello. Before we discuss the cases, for those who are watching Dental TV, on the right-hand side of the video player, there is a real-time chatting window for you to post questions to us and share comments. Let's go to the question that needs to be considered. The patient is 24-year-old male. He is referred to us. Place implant number 22. There is not enough space to place an implant at 22. Do I need to place an one-body implant like MS, or do I need to place the smallest diameter implant? The alveolar bone is very narrow. So do I need to do GBR? If a bridge is to be done instead of implant, what about Maryland bridge? If the tooth axis is very closely located, do I need to ask the orthodontist to change the axis, even though it takes some time? The alveolar bone height and the width are deficient. What do you think, Dr. Kim Kyoung-won? First of all, on the maxilla, the lateral teeth space is very narrow. As the dentist who sent us the question said, sometimes we use one-body implant, but we need to be careful when we choose that for the maxilla. Professor Kim Yeong-taek, I don't think this is a very challenging case. It's worth discussing what others are thinking in this kind of a case. I believe the patient was referred by the orthodontic department, so maybe we need to discuss this matter with that department as well. We can enjoy the discussion here. There are not many options available in this narrow space. The answer is already there. 3.0 diameter fixture needs to be used here, but can we trust it? 3.0 millimeter diameter implant. That is the point of this discussion. Now let's hear from our panelists in terms of how they are going to approach this kind of case. Professor Kim Yeong-taek, would you like to go first? On the panorama X-ray and clinical photo, the space is narrow. If you look at the width, an implant can be placed even though it's narrow. And CT image is sent to us. Most conical bone width is 5.45 millimeters. We need to calculate the gap between the teeth. So how close an implant can be placed to the teeth. And if we invade into the root of an adjacent teeth, that would be a disaster. And we need to think about how close can the implant be placed near the teeth. Dr. Tanao wrote a paper on this. He studied the bone resorption, vertical and horizontal bone resorption, depending on the distance between an implant and a tooth. The shortest distance was 0.1 millimeter and the farthest 1.5 millimeters. When the distance was 1 millimeter or less, there was a significant bone loss. When the distance is bigger than 1 millimeter, there was no problem with the platform switched implants, so no bone loss. In conclusion, we need to secure 1 millimeter distance. We had 5.45 millimeter gap, so we need to subtract 1 plus 1, and therefore the distance is 3.45 millimeters. We can place these three types of implants, but the middle one is MS denture, so we need to choose between the one-body implant or the narrowest TS3 3.0. One-body implant is called one-piece implant. If you read the paper, you will know this. As far as I know, this is prosthetically very unfavorable. You can have 5 degrees on both sides, so there is a limitation in the angle, not to make an undercut when crown is fabricated. And it is too small to prepare. In forming margin, it should align with soft tissue, so it is very difficult. And it is difficult to place an implant considering that. And even though the tooth is thin, number 2, the CJ part is not very narrow, therefore prosthetically it is very unfavorable. When I placed an one-body implant, the prosthodontist in our hospital actually gave me death glare. He asked me not to place that. In local clinics or in university hospitals, or some dentists prefer that, but it is not the case in our hospital. It is periodontally unfavorable because there is no platform switching and only cement type can be used. Cement remnant causes periimplantitis, and when cement melts away, a gap is created. Therefore, periodontally, it is not good. I introduce various theories and based on papers. In 2020, a systematic review and meta-analysis paper is published, so I brought it here. It has 1-year follow-up. Systematic review filters many papers under certain conditions, and a few papers are selected out of several thousands, but those papers selected are very relevant ones. It's observed for a year, which is a disadvantage. Short-term survival rates and incidences of complications are looked at. One-piece implant and two-piece implant showed similar short-term survival rates and incidences of complications. Despite that, the two-piece implant platform switching showed better paper implant bone loss. This is a table. Platform switching versus platform matching. The two-piece implant with platform switching may be a better option to reduce peri-implant bone loss. The survival rate is similar to one-piece implant. The two-piece implant with platform switching showed statistically significant better in terms of bone loss. Narrow implant itself, is it safe? There are many papers on that topic, but I brought a systematic review and meta-analysis paper, as it has very good summary or conclusion. Narrow implants are divided into 3 categories: less than 3 millimeters, 3 to 3.25, 3.3 to 3.5. Less than 3 millimeters means one-piece implants. The one-piece implant is compared to the standard implant. Next, thin two-piece implant is compared with the standard 4 millimeter implant. The survival rate is poor in category 1 when the diameter is less than 3.0 millimeters. Here it shows the same thing about the one-piece implant survival rate. It's not very good. Category 2, 3 to 3.25 millimeters in diameter. The narrow implants, there was no significant difference compared to the standard implant. P-value is 0.92. It is close to 1. Therefore, the results are the same between the two. Category 3, it is bigger in diameter, but the P-value doesn't show the statistical difference, but just shows the trend that we can identify. There is a reason for that. One-piece implant compared to standard implant is not very good. It can be due to severe atrophy, so we need to consider that factor. If you review the papers, you will be able to see the difference. In category 2, there was no difference in implant survival compared to standard implants. However, category 2 were mostly used in anterior single-tooth restorations, so there was no significant difference from the standard implant. 3.3 to 3.5 thicker implant, there was no significant difference. It is also placed in posterior region, premolar, therefore, so the conclusion was derived. We cannot reach a conclusion based on these two papers. We need to review more papers. I don't try to use one-piece implant because our prosthodontists do not like it. I try to use two-piece implants as much as possible. Let me introduce the latest case, which was placed in December last year after ortho appliance was removed to place an implant congenital missing. Spaces for 32 and 42 were created orthodontically, and the patient came to me, and the implants were placed 3.0 by 11 millimeter implants. For number 42, the prosthesis was delivered on the day because of good initial stability. The temporary was connected, as bone width was not bad. The patient is about 20 years old. There was no atrophy, so no bone graft. Number 42 is okay. I placed a non-OSSTEM implant at number 32, but it was removed the next day because of lack of stability. I waited, and 1 month later, without drilling, I placed the implant again. 42, temporary was delivered 1 month before, and 32, it's immediately done like this. It is used pretty well. I don't fabricate temporary hurriedly, but in this case, the patient was to go abroad. Since then, I haven't heard anything. I think there's no problem because the patient was a daughter of my friend who should have told me if there were any problems. And if you look at the angles, they are almost in parallel according to the panorama X-ray. Less than 3.4 millimeter tapered type as it goes narrower. TS3 3.0 by 10 or 11.5 would be okay. 11.5 millimeter length would be okay too. Considering it's in anterior region, one thing to note is that the width of 3.20 implant is a 3.2. It barely fits into the space, therefore you need to do the surgery very carefully. If possible, it's a concave area which requires GBR. Dr. Kim Kyoung-won, I believe we will talk about that. So this is the recommendation. It should be in the housing. we have ortho department, so I consulted this case with them to change the tooth axis. It takes more than 6 months. Still, it's not for sure, and we are talking about 24-year-old men. If you communicated fully with the patient, it can be done, but already the root of number 1 is distally inclined. We can do it. If a further ortho treatment is remaining, we can change the axis. However, if the ortho treatment is already completed, we can afford to fight with the orthodontist, and we can go along with that. Thank you, Dr. Kim Kyoung-won. Fortunately, as Professor Kim Yeong-taek said, this is a very narrow space and looks like the ortho treatment is almost complete. Therefore, we need to select narrow fixtures. As you can see, clinically, the labial bone is concave. Between the teeth, the space is very narrow and labial bone is resorbed. GBR is required here. Recently, I use titanium mesh for GBR. Let me show you a case. The patient came to me for the first time in 2012. The patient was referred to me. In quadrant 2, the premolars are missing and the canine as well. The ridge is very narrowed clinically. On the cone beam CT as well, the ridge is very narrow and is collapsed. The width of the residual bone is not good. If you place an implant there, the occlusion with the antagonist tooth will be a problem. Based on the remaining teeth, the tooth axis will be distorted. At that time, I began to use the titanium mesh. Incision is made. 2.0 drilling and the guide pin is connected. Already dehiscence or penetration appears. I was thinking about GBR, so I used the regular 4.0 millimeter implants. 3 of them are placed, and the bulk of bone already shows dehiscence or fenestration, and bone graft is done. At that time, I didn't have very good impression about the titanium mesh because I had difficulty when I used it when I was a resident. I used the Smart Builder with good fixation. Allogenic bone graft is done. Titanium mesh is used. The cap is a little bit different from the one we use today, and GBR is done. As GBR is done, the flap is short, therefore it is important to do periosteal releasing incision should be made to suture tension-free. People ask me how to prevent the breakage of suture. I tend to do like that. I don't like rough surface things, so I don't wear the Korean traditional shirts with rough texture, so I use silk. People ask if silk is okay. Yes, I use a silk. Stitch out after 1 week and good healing after 2 weeks. About 4.5 months later, after I used the allogenic bone, the second surgery is done. Os builders are removed. The alveolar bone is formed pretty well as I expected compared to surgery done in March. Relatively, the bone is grown pretty well. Immediate post-op. The second surgery was done post-op 4.5 months and the follow-up at 2 years and 5 months. The ridge was palatally inclined, therefore the axis is not very good. After 2 years and 5 months, the augmented bone still remains. It is not excellent, but it is maintained, and the patient is very much satisfied. Allogenic bone is what I used to use in the past. Allogenic bone tends to be resorbed, so today, even when I use OSBuilder, I use allogenic bone in contact with the host bone, and bovine bone is covering the site. When we have a very thin gingiva, collagen membrane covers the site. Thank you very much. Dr. Park Jong-hyun, may I ask a question? The collagen membrane, as far as I know, titanium is not really GBR. It is just forming the shape. Don't you think a collagen membrane needs to be used there? To be honest, at that time, the price of collagen membrane was very expensive. As I was with the university hospital, if we use a cytoplastic, it would cost hundreds of dollars, and the patient was burdened by the price. As Professor Yeong-taek said, today, titanium mesh has big pores, so it is not really GBR concept, but space maintenance concept. Therefore, these days, I use OSSTEM source guide or more reasonably priced collagen membranes to cover the site. One more thing, when the ridge is very thin, for example, 3, 4, 5, which is not heavily loaded, number 3 is changed from canine guidance to group guidance because of implant placement. I place thinner implant, like a 3.6 millimeter diameter implant. If the deficient area exists in the arch, I would do GBR there, and the rest, maybe the prosthontist would not like it. The upper part can be compensated with the prosthesis. What do you think about this approach? At that time, about 10 years ago, in 2012, titanium mesh, in the late 1980s, I didn't have good experience of using the mesh, cutting the mesh by scissors, and it tend to be exposed. The OSBuilder from OSSTEM is formed three-dimensionally. It is much less exposed and very thin, easy to use. As Dr. Kim said, at that time, I thought about placing thicker implant 4.0 diameter because I had a GBR in mind as well. In this case, even if I use narrower implants there, I don't think I could avoid fenestration or dehiscence because the bridge was very narrow. My point is, you can use a thinner one. If 4.5 can be placed, the 4.0 is used. From GBR to bone graft, the concept is changed for me. GBR bone augmentation influences the long-term stability of implant quite seriously, so I try to put implant in the bone housing. What do you think? Do you really do GBR or do you opt for conservation? In the past, autogenous bone, even block bone, was used. Today, in Korea, when I explain to the patient, when a patient comes to us, they come to get an implant not for bone graft. Of course, the patient needs to have a bone graft, but their impression is the dentist wants it more. That means when ramus bone is harvested, patients complain pain, not in the implant site, but the area where the bone is harvested. Recently, I don't do a lot of autogenous bone graft. As I said briefly before, OSBuilder, the space-maintaining titanium mesh can be used. Still, I use the graft material. where in contact with the implant surface or host bone, allogenic bone is used for better regeneration, and over it, bovine bone is placed. That's the layered graft, which is a better term compared to the sandwich graft, and titanium os builder is used. And on the soft tissue side, you can see the see-through of mesh beneath. Collagen membrane is used over it as more reasonably priced collagen membrane is available these days. Dr. Park Jong-hyun, please. Dr. Kim Kyoung-won showed very impressive cases. I'm not skilled at bone grafting. I try to use existing bone and teeth. So let me show you such cases. The minimum space to place an implant, it should be 6 millimeters on CJ level for TS implants. To place an one-body MS implant, it should be at least 5 millimeters at the CJ level. That's the minimum space. 5.4 millimeters is the space in the case under discussion. Let me show you a case. I really love to use one-body MS implant. I've never experienced any failure with that. As Dr. Kim showed us in the paper, one-body success rate is lower. What is the reason for that? Maybe fractures or complications. Bone resorption is also pointed out. The crown is not properly made. That's what I expected. I just realized the problems and I really didn't check the causes properly. The greatest disadvantage of one-body implant is you have to immediately load it, even though for the same 3.0, if you place an one-body implant, you have to risk the immediate loading, so you cannot use it in a deep bite patient. So I have to choose proper cases. 1 year, 6-month recall image. It is functioning pretty well, I believe. I believe it was a very good choice. Come to think of it now, I would place MS implant in this case as well. There's no micro gap or micro movement. I've never experienced bone loss with MS implant. 4 years and 2-month recall. Soft tissue is stable. Relation with bone is very stable. But we cannot achieve this outcome routinely. Immediate loading is the risk that I don't like. As Professor Kim Yeong-taek said, if the placement direction is slightly off, prosthetics would be very difficult. What about not loading it immediately and you wait after placement and do crown later? But there's something sticking out like this as you are doing it confined to the anterior region. So something can go wrong if the patient chews on something weird. I believe one-body implant is a good choice in a very narrow reach. We have a guide. In a narrow reach, we can place the implant easier. Psychologically, 3.5 diameter non-X fixture is my limit. That is resistive to fracture. Psychologically, I feel comfortable with that as the limit. I was impressed by Dr. Kim's placing of an implant in a very narrow reach. It was very impressive. There's a less fracture risk in the anterior region, but still 3.5 millimeter is the smallest one that I use for psychological comfort. Sometimes this problem occurs. If the palatal bone is too hard, implants sometimes get placed too palatally. In the apex, there's hardly any bone left, and the marginal bone is 1 millimeter. So this is the limit for not doing bone graft, and I didn't do the bone graft here. It is slightly buccally inclined. It is placed where ER type is enabled. In the anterior region, ER type is very important. Subgingival margin should be fabricated, and removing cement intraorally is a very tricky job. To remove it intraorally, the ER type with palatal screw hole should be used. It was fabricated with ER type. Definitive prosthesis. The condition here is not as good as before. Palatal hole could be made in the previous case, but the bone width is very narrow. Making a palatal hole is not as important as putting it in the bone. ER type can be given up, and the guide is used to place it. I always feel whenever I use a guide, when the palatal bone is not as hard as this, you can place an implant very accurately with a guide. When the palatal bone is hard, it cannot be placed very accurately. This is something I have not resolved yet. This is a tip for anterior cementation. Palatally, I use supragingival margin. If it is subgingiva 360 degrees, when the gingiva is firm, settling is not easy. If attachment is not done right, it's difficult to retrieve it. For retrievability, I use PFM with a 10 bond. If you use a zirconia prosthesis, it is not easy. If you can use only cementation in the anterior region, I try to use PFM prosthesis. In a narrow space, this is the X-ray of the case under discussion. 3.0 implant is the answer. Even though it is placed properly, prosthesis is the problem. The embracer creation is also difficult. The narrower one-piece rigid abutment 4.0 can be applied, and then we have more room for prosthesis. I hardly use the rigid abutment. Compared to transfer abutment, this is more beneficial. In a very narrow space, my idea of bone grafting, the bone width is not that narrow. With bone grafting in mind, I perforated the site for bone grafting. Before I drill, implants are placed and the bone graft is done. The bone is thick at the top. At the apex, there's a concavity. Likewise, the implant is placed to increase the volume. Bone graft and membrane are applied. Here, it looks like the implant is too thick in a narrow space. This is non-hex implant 4.0 by 10. I use a non-hex implant because that is more resistive to vertical fracture. Bone graft is done. After the placement, I regretted when I took the CT image. Why did I use a guide to place it? Even though there were enough bone, the hole came out labially. As I said before, for retrievability, PFM prosthesis is used. It is very important to sandblast the abutment to keep the temp bond. It was a good case to make the hole to come out palatally. If I didn't go too far in terms of the length and the diameter, it could have been placed very well without bone graft, but the placement direction was off and unnecessary bone graft was done. As for the bone graft, It is good for keeping the volume. It is very important to keep it static anterior. However, if we reconsider the direction of placement, if the direction of the placement is proper, you don't have to do the bone graft. In cases like this, what I learned from here is that I shouldn't be audacious in terms of implant length in the posterior and diameter in the anterior. If I use 3.6 millimeter diameter and placed it in this direction, I could have boasted about this case here today. That's my regret. Would you go back to the slide, please? As I see it, 3.6 millimeter diameter is good as it is number 2, but tooth axis on the left is better for me. Under the assumption that bone graft is to be done, I am doing a lot of GBR from my perspective. In that case, bone graft can go wrong. There's a higher chances of that occurring, even though you use membrane that will be resorbed. Decortication would be difficult because implant would interfere in it. If cortical bone is thick, decortication is difficult. The bone graft can be successful, but there is a possibility that it can go wrong, so I will choose the left and I'll ask prosthodontist to do the rest of the work, apologizing the whole direction is not very good. And I'll ask the prosthodontist to use a cement or lateral screw, whatever. The supramargin looked pretty good. If the bone at the apex is not ossified, what kind of problem can we expect? Peri-implantitis occurs. I saw that. I have many patients who have problems. When the bone is not completely ossified, it becomes painful and the peri-implantitis can be resulted in. As someone who does a lot of bone grafting, I don't like that. Then I'll do like this. Palatal hole is more important, so I will place 3.6 by 7. Then it can go into the bone housing. Isn't it too short? What I feel listening to this conversation is prosthodontists also have a lot of difficulties. If I am doing this treatment, I would go for the left. That means I did the right job initially. Yes, I think so. Thank you very much. I will think about this a little bit further. Maryland bridge. I like to use it in the mandible. I've never experienced the fallout of Maryland bridge. It is attached at one side on the enamel, and this groove is not to maintain. That helps for cementation. The resin cement needs to be attached very thinly. If you don't have that groove, it's hard to find the right place. Using this, the thin resin cement can be attached very accurately at the bottom. 5-year recall. The Maryland bridge has never fallen out since I opened my office in 2012. It is a very attractive option for the mandible. If the tooth is mobile due to periodontal reasons, it's even better. It doesn't fall off. If it is attached on both sides, it can fall off. The one side attached to Maryland bridge doesn't come off that easily. This is what I said before. I don't even place one-piece implant if the space is less than 5 millimeters. The space is 4.4, so Maryland bridge is a choice. The maxilla, I used it only once. There's a problem of using it in the maxilla, and I have no intention of doing it again in the maxilla. It should not be in the occlusion or guide. The area where we can use it is too small and the teeth are too Even though it is not in occlusion or guidance according to the articulation paper, the patient can chew cucumber or bite on an apple. Using the groove, attaching it properly is the key point. 2017, the patient came back for scaling and it is still maintained. I was really impressed by that, but the patient seemed to be thinking, what does it have to be so impressive? And the patient of the case under discussion, a similar patient came to me recently and I would do a bridge with cantilever. Canine would be reduced and a bridge with cantilever is something I can do skillfully. I'm not as confident as Dr. Kim in placing 3.0 millimeter implant in such a narrow space. I will become a culprit as soon as I invade on the adjacent tooth. Summary: MS fixtures' biggest disadvantage is immediate loading needs to be done. It is unfavorable for a deep bite. I have never used it in the lower anterior region except the one I showed you before. 3.5 millimeter diameter fixture is still the smallest one psychologically. I will use 3.0 after more accumulation of data. I showed you 3.6 millimeter cases. That's the regular platform. If I have mini platform abutments, that's too many. Therefore, I use up to 3.6 millimeter. Bone graft is good if you're skilled at it, but if it is not done properly, it'll be worse. Maryland bridge is good for the mandible, but it is used as a long temporary in the maxilla. It is not to be used as a definitive prosthesis. Mesial cantilever bridge is used for these cases. If the patient insists on getting an implant, I would refer the patient to Dr. Kim. Thank you very much. The three panelists gave us very good advices. Let's go back to the case under discussion. Based on what we have discussed, then what's your last remarks? That case, we need to use narrow implant. As Dr. Park said, 3.0 millimeter. Placing it is even not easy. Digital guide and OSSTEM's one guide is available, but therefore they can be used to place the implant as planned. In this case, GBR is necessary. Dr. Kim Yeong-taek? First of all, I need to consult with the orthodontic department to change the tooth axis and to widen the space for the placement. Otherwise, a 3.0 millimeter diameter implant will be placed. Using a guide would be a better option. I'm not really used to it, but we should make matters worse. Therefore, we need to properly place the implant using a 3 millimeter implant. Dr. Park? I'm very surprised. Did you place it without a guide? Using a guide is very difficult for me. I'm afraid of a very narrow space. I will choose what I can do. I'm a local clinic dentist. I will do what I can do and I will refer the patient. Are you going to do the bridge? Yes, bridge. Case discussion, we talked about how to deal with narrow space for placing an implant. Thank you very much for the good discussion. Gratitude to Dr. Kim Kyoung-won, Professor Kim Yeong-taek, and Dr. Park Jong Hyun. Thank you very much. This concludes the discussion. I am MC Dr. Kim Se-jin. I'll see you next time. Thank you.
감사합니다.
수고하셨습니다. 고생 많으셨습니다.